because they are the ones that clip, the ones that have the end that clips. You don't want that. It's a lot more difficult. Yes, it locks. It's a lot more difficult because now the procedure depends on you separating these two, putting them back together and separating them again. You want that process to be as seamless as possible. So you need a 10cc syringe, that's sterile. The black needle is 22 gauge, and they need to be at least 30 millimeters. So these are 5 or 25. This is 32. This is 32 millimeters. So you need to ensure that you have the correct level.
But with muscle, like I said earlier, is difficult to biopsy. It's harder, so you can say we might not be seeing a lot of cells there. But this would be sufficient in this particular context. Then the reports will become as like a spindle cell lesion, formal core biopsy would be advised, because it's difficult on cytology to actually just tell in most cases what is the type of the spindle cell lesion, especially if you don't have access to ancillary testing.
Yeah, this one I'm seeing is like VCV malaria parasites.
It looks like malaria parasites.
Yeah.
Yeah, those are spindle cells of the mouth.
Is it? Yeah, the tip.
Yes. Okay.
And then you ask yourself, does this result require triage or does this result require treatment? Nah. So you do a pap smear comes back, it says it's normal, it's obvious, we go back to screening. Now you do your pap smear and the pap smear comes, it says low grade SIL. So we're thinking here there's probably mild dysplasia. This can be caused by many things. Now it could be HPV, it could be some vaginitis, it could be the use of tampons and many of the things that sometimes go in there, resulting in cells that are mildly dysplastic. So this is an inconclusive result and it requires triage so that we know what is it that it really means.
Yay! Good evening, colleagues. I actually wanted to record so that I don't forget. How is your week so far? We are about to wind this one up. I hope that so far it's been great. From my side, it's just an awesome one and just full of things I need to be grateful of. So as long as I get an opportunity to connect with you, I always, feel very good about myself. Yeah, so today we are going to be discussing big things there, pharmacogenomics. Do you guys know what that is? I can tell you that I also don't know what it is, but what I know is that in the next hour, I will know exactly what it is because I am not alone. I'm so grateful to host Dr. Lizelle. Welcome back home, Lizelle.
Thank you so much, Dr. Secho. It's always nice seeing you guys.
Yes, colleagues. That is Dr. Lizelle Brown, our in-house instructor for pharmaceutical related topics. I really appreciate these collaborations. That's hence we call ourselves a platform. That means we are a place where those who love teaching can meet and interact with ourselves who really love to learn. So yeah, let me go through my sort of slides and then take you from there. So just to remind you that as a platform, we have a mission which is to improve patient care. And if you're joining us for the first time, I want to invite you to commit to this mission, which is to improve yourself, which is to get better day and day. So yeah, what an awesome time this is. Yes, we are a membership-based platform. So remember, all educational events, particularly our evening webinars, you may attend as needed. Though that benefit is about to lapse because from the 1st of October, our webinars will be accessible to members only. So yeah, do consider that. But for today, join in, enjoy your learning, and hopefully you join us so that you are able to get more administrative support, certificates, etc., etc. Yes, and to join us, visit our website www.clinicalcareplatform and check out what we offer. There's going to be more and more offerings, and I'm so excited because there's something we will be launching in the next couple of days, early September. So our members, be on the lookout for that, something that will really help you to grow at a personal level. I know you are already great professionals. But in addition to your core skills, there's other things that you really want to invest in you. So our leadership note for this week has been about the importance of growing yourself, so that you are able to elevate what we call your leadership lead. And you can see this quote by my mentor, John C. Maxwell, because I'm learning a lot of leadership from his books and his programs. Says the personal growth increases. So it gives us hope that tomorrow can be better. It teaches us that tomorrow can be better than today. But to be better tomorrow, you must grow today. And to grow today, you need to commit to learning. And as a platform, we have committed to give you that opportunity to get better. I wanted to say that our diploma preparatory programs are open for registration: HIV, internal medicine, obstetrics, etc., etc., child health. And guess what? We have new ones, which we will be starting with this particular intake. So this intake is for people who are planning to write the February exam in 2026. So we will be starting the coaching programs in October, November, maybe the first week or so of December. Take a break, then wind off as we prepare you for this important success. So anesthesiology, we will be running that, but also ophthalmology is going to be one of our point of interest. I can't seem to see the ophthalmology one, but yeah, it's coming soon. For our members, know that you have 10 additional micro lessons which are CPD accredited. If you have missed any of these, you can just log in on the platform to get your ethics points or even some of the clinical topics. This is one of the great benefits that CCP members have. So we hope that you would enjoy this. We do have paid events from dispensing license to NIMART to basic HIV, advanced HIV. So if you do have a specific need, do check out our academy. And we are going to wind down this month, or probably start September, with a masterclass on updating all NIMART nurses on key policy changes. If you are a nurse, this might be a program of interest. It will be on a Saturday. It's a virtual event, so regardless of where you are, you can join us. But what I'm excited about is the one that's coming this weekend. We are going to be discussing cervical cancer prevention and management. It's a masterclass with Dr. Billy Magagula, and you would know that September is a very important month for cervical cancer. So yeah, I'm hoping that you are planning to join us. I did play a snippet, but I'll share the link, though I think I did share earlier on. Show me your thumb if you are from KZN. Who's from KZN? eThekwini, eDebheni. Show me your thumb. Anybody from KZN? Ooh, nobody. Oh, there we go. Last year, we held this boot camp on how to do an FNA. Some of you are nurses, you want to run an FNA clinic. Some of you are GPs, you want to do this procedure and enhance the profitability of your business. We ran it in Joburg. I'm sure you saw the snapshot that I was playing. We have now agreed with the same team that we are going to run it in KwaZulu-Natal, eDurban. So please be on the lookout, get yourself ready. You still have almost 60 days because it's 25 October. This is in person. You have to learn how to aspirate and do all those kinds of skills. Very excited about it. Let me not bore you as always with my stories. Today we are discussing pharmacogenomics. Hey, it sounds very serious, Lizelle. I don't know what this is all about, but I can tell you in the next hour I'll be asking a lot of questions, to Lizelle. I don't know. I don't want to read Lizelle's profile except that we are so grateful, Lizelle, for this partnership. I just want the Lord to continue to bless us so that we are able to continue to be very impactful to health workers and helping them to be better versions of themselves and to achieve their highest potential. Dr. Lizelle is a very experienced pharmacist with a long history in teaching many of the pharmacy qualified people in South Africa. She has a master's program, but also she's a PhD graduate in the same field, and she loves research. That's what I know. So if you are struggling with your master's dissertation or things like that, just drop Lizelle that WhatsApp. I can tell you she will help you to qualify very, very, very soon. On that note, Dr. Lizelle, can I hand over to you so that you can take us through today's presentation? Welcome. Yes, you can. You can share your screen.
Okay, so just go quickly there.
Yes.
Yeah.
Welcome, colleagues. Are you good?
Okay, I'm there.
Yes, we can now
Okay.
see your slides. Thank you.
Okay, thank you so much, Dr. Seger, for this opportunity. It really was a new adventure for me, and I heard about this topic a long time ago, but I've never actually went and had a look at what it encompasses. So tonight I'm just going to give you guys a brief introduction of what pharmacogenomics is, and then I have added some video material that I downloaded from YouTube for us because yeah, it's nice and interactive, and they explain difficult things in a more explanatory, understandable manner. For me, it was way of learning. So let's start with tonight's webinar.
Lizelle, I'm not sure if colleagues, are you able to hear Dr. Lizelle? Okay, Lizelle, maybe let's switch off your video and see if we can manage. Let me do that for you. Oh no, they say they can hear you, so it's mainly on my side. It's okay. Thanks. Continue.
Okay. So just a disclaimer from my point of view is that I am not a genetic specialist or a genetic counselor, but I downloaded some videos, like I said, from YouTube, which we can look at. The advertisements that precede that is done automatically. So I'm by no manner endorsing or advocating any of those items that are shown. Okay. Slides don't want to.
Hi, Lizelle. Just click anywhere on the slide with your mouse. It should move. Thank you.
Okay. Right. The aim is to briefly discuss some aspects of pharmacogenomics. It gets abbreviated by PGX, so we'll refer to pharmacogenomics in that format. Basically, in a nutshell, the objectives that we are going to look at is to look at what pharmacogenomics is. We are going to look at different aspects pertaining to pharmacogenomic testing, and then we are going to look at the role of or the future of pharmacogenomics. Okay, I just see this. Take that away. And I just want to take this toolbar. Okay, so pharmacogenomics is an expanding field that is to a lot of healthcare providers and patients. It plays an important role in predicting the results of the types of medicines that people take and focusing on the specific genes. Pharmacogenomics can provide a valuable insight into structuring of a precision or personalized medicine. And we'll look at that later on. Very interesting. Just remember this sentence: a one-size-fits-all medication approach does not exist. So we'll look at that, and we'll look at how healthcare providers that look or use pharmacogenomics can then take a look at a patient in a more holistic manner by making dosage changes or changes to medicine, even for optimization of medical outcomes. Okay, so here I've got a couple of frequently asked questions. And the reason why I put them there is the questions that are asked here is going to play a role in what we are going to deal with. So I've given a couple of questions. We'll quickly look at them, but we will go into a little bit more detail about what they indicate. Since pharmacogenomics takes a holistic point of view of a patient, I then thought maybe I should start the presentation off by asking a lot of questions about pharmacogenomics. And then from there on, we can get an understanding, and that can make the presentation be more fluid and understandable. So what is pharmacogenomics? It's the study of how genes, all of us have genes, and we'll see that in one of the YouTube movies, how our genes affects our response to certain medications. For example, you'll get, we all know of the cytochrome P450 enzymes and how they influence drug metabolism. For example, some individuals will be quick metabolizers, some won't be quick metabolizers, and that all comes from looking specifically at a person's genes. So why would you want pharmacogenomic testing to be done? It is basically there to look at what genetic variations a person has. And incorporating that then in consultation with a healthcare professional to gain insight into how is that individual going to respond to certain medications or not. Applications are absolutely wonderful because it directs applications towards personalized medicine, where professional healthcare professionals will be selecting and dosing medications in a more precise manner, and that could then result in better treatment outcomes. Limitations, obviously, with research and information that are exploding, the limitations for pharmacogenomic testing is currently only focusing on a number of genes and variants, not all of them. And then obviously also certain medications have been implicated. And we'll see that the FDA list has got, I think, up to 80 different indications where one could then apply pharmacogenomic testing for. Risks of it, well, there's always a risk in providing inaccurate results because not all of the genes are tested for. benefits. That is absolutely a way of empowering individuals to be active participants in their healthcare, because by selection of certain medications and looking at what the pharmacogenomic tests results are, medicines can be chosen to have fewer side effects, or ultimately improving treatment and safety and efficacy by, for example, dosing adjustments, or looking at completely new drugs to look at. The future looks bright. A lot of research is put into this, and it's aimed at personalized drugs for every person. How do genes affect medications? We know about the cytochrome P450 enzyme system. And that can, for example, you can look at that can influence the way that certain medications are metabolized and how other medications aren't metabolized. There's a nice video on that will demonstrate that for us. Applications, well, that's self-explanatory. You want the best medicine for the right patient at the right time, at the right dose, etc. Advantages, we've said that there are numerous advantages specifically aimed at personalized or drug therapy. That's one. The role of pharmacogenomics in precision medicine, I'm going to hand that over to one of the videos to explain that to us better, as well as the importance of pharmacogenomics in personalized medicine. Basically, in a nutshell, it's crucial because it needs to be the information that is gained from different gene sequencing and certain genes will help a healthcare professional to select the most effective, safe medication on an individual based on their genetic profile. So pharmacogenomics is made up of two words. The first one is pharmacology, which is the study of uses and effects of medicine. And the other word is genomics, which is the study of genes and their functions. So pharmacogenomics is a study to see how are our genes affecting the way we respond to medicines. So we spoke about precision medicine, which we want, because sometimes a person will take a certain drug for a specific illness condition or disease state, and the patient will not give or will not display the results as expected. So this is where pharmacogenomics plays a very interesting part in guiding healthcare professionals to look at whether or not the drug the person is taking, does genes play a role in them either being slow or fast metabolizers? And then what's nice of it is currently pharmacogenomics only has a limited number of health conditions and medications. So we'll only look at a couple of disease conditions that we can look at. On your right-hand side, you'll see that there's a group, let's call it a small population of patients taking the same medication. Two of them, the yellow ones, will have no response. Two of them on the left-hand side will have serious side effects, and the rest will have a desired response. So let's see what's happening here. Okay, I have listed 6 key aspects of pharmacogenomics in here. We can just briefly look at them. the importance that we need to understand is that there is genetic variability among us all. We all metabolize certain drugs at different rates, and that depends on different uh, genes that we have, whether it's a family history of genes, or if you've got certain illnesses, or whether certain genetic variations occur in certain populations, etc. Drug metabolism, yes, we spoke about what um, the role of cytochrome P450 genes have, and in particular, the CYP2, CYP2C enzymes play a predominant role. So I've highlighted them in the presentation, although there are other genes, for example, the hERG genes that are also implicated. But I just decided, now let's just look at cytochrome P450. So some people can be poor metabolizers, meaning that they metabolize their drugs slowly, and that leads to an increased risk of side effects. Others are ultra rapid metabolizers, meaning that the patients metabolize their drugs quickly, and that can lead to reduced drug efficacy. Clinical applications, yes, there are a couple of clinical applications applicable. Oncology, psychiatry, cardiology, or some of them. We'll look at others as well. Obviously, genome testing of genes raises ethical questions of, for example, genetic, genetic privacy, for example, access to testing, whether or not medical aid or health or insurance, for example, pays for that, etc. The regulatory landscape is basically to increase the interest from regulatory agencies, giving them guidelines for testing, how to interpret the results, and ultimately to develop a companion diagnosis. Future directions, yeah, definitely a lot of future applications, which I am so excited about, because that'll enable healthcare professionals to tailor-make drug therapies based on the genetics of the person, the patient. Okay, now we are going to look, I just want to shift these little things out of my way, these toolbars. We are going to look at a video now that will illustrate how genomic sequencing works. And so let's go.
Hi, Lizelle. Hi, Lizelle. I see we don't have sound. We can see, but we don't have sound. Is that the link? Okay, colleagues, I will share the link with you after. Maybe I'll also replay the video at the end. I'll just copy the link. It's okay.
Was there a problem, Dr. Secho?
Yeah, just the sound was not audible. So I will replay the video at the end, so you can continue. I see the link here.
Okay. When we look at what pharmacogenomic testing is, we look at one or more genes that specifically challenges or impacts on medication breakdown. So what they usually do is they either take a blood or a cheek swab, and then from there on they send it to a laboratory where DNA testing is conducted. The pharmacogenomic testing process, there are several steps. In summary, there are four. First of all, you need to collect the sample, which could either be in your saliva or blood, and it's collected from the individual, obviously. Genetic analysis, the DNA in the sample is sequenced and analyzed to identify specific genetic variants. And the previous movie that I showed illustrated that very nicely. I don't know why there's a sound problem. Maybe it's the internet. Okay, so once that genetic analysis is done, the data is then interpreted, and it is compared to see if there are any associations with drug metabolism and drug responses. And then lastly, obviously, the reporting of those results to your healthcare professional, who can then use that information to make and guide treatment decisions, specifically, obviously, for prescribing. Let's shift this. I don't know what. Okay, what does pharmacogenomic testing do? There are several reasons for you, but you need to find out if the medicine that you are taking is right for you. Meaning, does a certain medication that you take work for you or not? What would the effect be on the dose, and what would the best dose be for you? And then also asking you, have you got any side effects, and are they serious side effects? So the laboratory testing of your genes helps to predict how certain drugs can be given to you, tailor-made to you. It is, however, important to know that a pharmacogenomic test is not only, it's not only one test that's done and it's done forever. You will have to, laboratories might perform multiple tests, and you need to keep track of those tests when going to your doctors, for example. Because research is ongoing, and pharmacogenomic testing is getting better and better and better. So it's a good thing to know. When should you have your genes tested, or what is the indications for pharmacogenomic testing? The symptoms that you experience could mean that the drug isn't, for example, broken down as expected. In other words, you'll get different side effects. So there's a list of drugs. Carbamazepine is one, allopurinol, clopidogrel, codeine, and tramadol, and we'll look at them later as well. Another indication would be a patient is not taking a medication due to unpleasant side effects or lacking of working. And we'll see that I briefly spoke about the fast and slow metabolizing metabolizers. Another indication would be if a medicine with a known reaction is linked to a gene. So predictions can then be made from there. And then any patient that is interested in getting testing. We want the following. We want to prevent serious side effects. We want to get the correct dose of the correct medicine, but not only the correct dose or the correct medicine. We want to recommend which medication, if there is a problem, can be substituted or the dose adjusted. And then obviously to link that, to make that your effects towards taking those medications will be optimal. Applications, there's a wide range of applications there. I've highlighted them there. Oncology, cardiology, psychiatry, pain management, and for immunosuppression. And at the top right-hand side, I have given examples there. For example, immunosuppressant drugs, opioids in pain management, antidepressants such as your SSRIs in psychiatry, statins for cardiology, antiplatelet drugs, and then obviously warfarin as well. Okay, applications. Okay, let's look at a couple summarized. In your therapeutic area like cardiology, your pharmacogenomic application would be to genetically test if the antiplatelet therapy that the people are put on is optimal. For example, when they are getting coronary stenting. In oncology, identifying genetic markers that can predict response or target certain cancer therapies would be wonderful. Pain management, by personalizing opioid therapy based on genetic variations can result in drug metabolism differences and also responses. So you can choose your opioid medication. You can structure it differently according to the list that the FDA is providing, and I'll give it later on. And then obviously in psychiatry, matching antidepressant medications to enhance treatment efficacy, because sometimes you'll be taking SSRI that you will not get results, and the doctor will wonder why. You'll increase the dose or decrease the dose or add another dose, another medication, ECT, etc., etc., etc. So to streamline that, pharmacogenomic testing would be wonderful to help enhance patient compliance also. So here is a couple of drugs that are used for high cholesterol, and those if you're taking those drugs, you might need pharmacogenomic testing, and that's all the statins. Pravastatin, simvastatin, atorvastatin, etc., etc. that's taken for example, for decreasing your cholesterol. In depression, amitriptyline, citalopram, escitalopram, venlafaxine, etc., are taken for depression. And there I've indicated that the CYP2D, CYP2 D6 and CYP2C199 affects the breakdown of these antidepressants. For cancer therapy or oncology, got your different types of cancers and different types of drugs that can be used there would be like fluorouracil, for example, or mercaptopurine, etc. It's worth testing undergoing a pharmacogenetic test. Blood clotting, we spoke about taking an anticoagulant such as warfarin. And then for clopidogrel, you see we've got the cytochrome 2C19 enzyme again there. And for HIV therapy, okay, there's a variation in the cytochrome 2B6 gene that increases side effects for efavirenz, etc. For the immune system, here is if you are having immune system issues, for example, if you have organ transplant rejection, you can look. It is because well, let me put it this way: when you take tacrolimus, for example, after organ transplant, you have to know that the cytochrome P450 enzyme systems play a role there. So you can look at your dosing structures also. So what are the factors that impact the response to medicine, and when is pharmacogenetic testing recommended or considered? There's a long list. There's many factors that impact how a person responds to medicine. This includes genetic factors, whether it's heritable or not. Are you taking other medications? What is your age, your gender, your race? Do you have certain illnesses or troubles in certain body parts? For example, having kidney or liver problems? Do you smoke? Do you drink alcohol? Is there any specific foods that you take? And then they've listed their weight loss surgeries as well. So bariatric surgery is implicated there too. So when might pharmacogenomic testing be recommended or considered? There are many reasons, and we've looked at them. Maybe to adjust the dose of a current medicine you're taking, or to reduce the risk of serious side effects, or finding other medications that works better for you. And that includes patient compliance. So let's look at this video now. It's finding the right medication for the right patient at the right dose. Let's go.
Hi, Lizelle. We don't have audio. Oh, my things here. We don't have audio. I think you can jump the videos. Okay.
Okay, the role of pharmacogenomics in precision medicine. There's another video that shows that certain genetic testing There are databases, the CyPIC database, the FDA database, etc., that can help you. I'm really concerned that these videos have audio problems because they are so informative. So let's skip them now, and then Dr. Sechel, maybe you can play them later because they are really very informative. Very informative. Let's go on. Skip this video, just hold on. Okay. When you look at making prescription recommendations,
Hi, Lizelle. We are still seeing the video. Maybe you want to click on the slides and move to the next slide.
I am on the next slide.
I'm still seeing let me see. Yeah. Maybe if you can stop sharing and reshare again, let me help you to do that. Because we are still on the video slide. Yeah. Can you reshare your slides? On the Zoom. Sorry about that.
Share, yeah.
Okay. It's coming. Yes, now we can see the slide on prescribing recommendations. Thanks.
Yes. So when we look at prescribing recommendations used in pharmacogenomics, it's aimed at, again, those wonderful words, personalized medicine or precision medicine. And that's guided by looking at your genes and making prescription recommendations. For example, when a person suffers from depression, the medication that he or she might be on, for example, is escitalopram, and the pharmacogenomic recommendation would be to reduce the dose if the person is a SAT2C19 poor metabolizer. Okay. In cancer therapy or oncology, if a person has tests that tests for the HER2 gene amplification for efficacy, that needs to be taken into consideration. And a person suffers from cardiovascular disease. We spoke about the different statins that they can be on. In this instance, it's Plavix. There is also a cytochrome P2C19 phenotype that's to be taken into consideration for dosing. So these are just examples of certain medications that a person can take cognizance of. I have not listed all the medicines here. It'll take a lot of time, but there are, in the videos that I played, there are links to the FDA that's got a register and a list of different disease conditions and drugs that one can look at. So I suggest you really invest in looking at those videos. So benefits would be improved drug safety, obviously. You would like to reduce having adverse drug reactions as far as possible, to enhance medication efficacy. In other words, to predict how the medications will work and what would be the best for that individual. To look at more accurate dosing, especially for those that are fast or slow metabolizers. To reduce healthcare costs. An example there could be, for example, a person that's on a specific psychiatric medication. He or she is not responding to that. They are either not responding at all or not responding as they want to be. The doctors make dosage adjustments and nothing happens. So pharmacogenomics can play a role in there to help see Is the patient metabolizing the drugs fast or slow, or is the drug a list on one of the FDAs, etc.? And then obviously a benefit is to advance drug discovery and development, specifically targeting more drugs and designing them by use of clinical trials in selected populations. Another benefit and a description is for personalized medicine benefits. In other words, tailor-made medication by selecting and dosing a specific medication based on an individual's genetic marker. To enhance medication safety, obviously you don't want your patients ending up in ER or having a adverse, critically adverse, if you can call it critically adverse drug reaction. You want your patients to be as safe as possible with as less risks and factors affecting the drug responses as best as possible. And then obviously improving treatment efficacy of drugs by the selection of the right medications. And sometimes that implies reducing trial and error process. And we spoke about that in the beginning, and we said that there's not a one-size-fits-all. So risks, obviously, sometimes you can get inaccurate results, and that could be because the testing companies may assume normal protein function, and the interpretations is built on that assumption. So yeah, that's something you need to consider. Another one is medication that's just changed without guidance. Individuals will have access to their pharmacogenomic testing, and they will decide, okay, they're going to make their medication adjustments like they think, and that's wrong. It needs to be done in collaboration with a professional medical healthcare professional. So it should never replace medical advice. We spoke about this. That's it's a summary of what I've just said. Now is you don't want to get potential inaccurate results. Medication changes can't be just made without guidance, and it's important for working with your healthcare professional. The advantages and limitations of pharmacogenomic testing is numerous. But obviously, as research goes on, research is conducted, research gaps are identified, new drugs that are brought on the board, registered illness conditions, etc., can all help make benefit patients by getting pharmacogenomic testing done. But one should understand that there are limitations, time, money, patient access, very important, etc., or limitations that they only test for certain genes, for example. That is a limiting area. One should also look at ethical and social issues. For example, having potential genetic discrimination areas where certain, in one of the videos, they spoke about Asian populations that were identified as certain population that were shown to be either slow or fast metabolizers of medications, etc. One should also look at costs. Lack of education, for example, this is the purpose of why this presentation is done is to get answers or get a basic foundation for us to work on for improving our patients' health and their health outcomes. And also, obviously, to integrate that into your clinical practice. The genetic markup is important because you have to, it doesn't, your genetic makeup doesn't completely explain how your body processes medications. So you have to look at your patient in a holistic manner. Are there any other medications taken by this patient that influences the other medications that they take? Does it influence their breakdown or not? Do they have other health conditions? How's their lifestyle? Do they drink alcohol or smoke? Do they exercise? And then obviously cost is a rated limiting step for that. There is also a research that needs to be expanded beyond populations of European ancestry. So other tests need to be, other research needs to be structured to include other ethnic groups due to the scope of this presentation. I didn't exactly go into all of the populations that have been, that research has been done on. So that's a limitation that we can think of. And then obviously gene coverage as well. And that's again an issue where future research can provide more definitive predictions and definitive answers. The future, wonderful. We need to generate, develop gene therapies so that you can get targeted treatment for specific genetic diseases. We need to increase collaboration between researchers and healthcare providers to integrate pharmacogenomics into clinical practice and ultimately making the patient benefit by that, because that's of utter importance. And then obviously expanding on pharmacogenomic databases will give an enhanced understanding of gene-drug associations. So in conclusion, pharmacogenomics plays an important role in the prediction of how different responses of medication are made based on genetic variations. We as healthcare professionals need to make informed decisions, and pharmacogenomic testing can play an important role there, because we want the best efficacy and safety profiles for our patients. And it also offers a wonderful opportunity for companies to invest in predicting and investing in more clinical trial studies focused on future precision medication, which will then ultimately lead to patients getting the best treatment. Okay, that's all I have to say. Now that Lesego, you have to play those videos. It's in your hands. Thank you.
Thank you, Dr. Lizelle. I have two. Let me see if just give me a few seconds, colleagues. But yeah, in the meantime, let's really appreciate Dr. Lizelle for making such a big topic seem so processable or feasible. So yeah, we are very thankful for that. Let me do that. All right, so I'm gonna try and play the videos. Give me a few seconds. The first one is this one. Let me see if I can get it. Okay, I'll tell you, maybe it's the Zoom thing. If I fail, then we'll just share. Okay, I need to stop your sharing. Dr. Lizelle, a few seconds. Replace, yes. Yeah, I see the video. Okay, cool. Individualized medicine. Very interesting, colleagues. That means you will get. I'm gonna play the other one that I found on the same site, Dr. Lizelle, and then we can then have our discussion. Few more seconds, colleagues. Okay, few seconds. Okay, and then I need to help my colleagues who are streaming online. Give me a few more. Let me find the share your screen button. All right. So yeah, there we go. Oh, I must actually find
the right medication can save a life, but a medication that works well for other people might not work for you and may result in significant side effects.
What happened to the audio?
The right medication.
Few seconds. Let me see. What am I missing? Go back here. Share sound. No. Just see before I share if I'm gonna get the sound. Yo. I get live on technology. Let me play before I share.
Can save a life.
Well, now I do have sound. But when I share, there's no sound. Okay, let me try again. If I fail, then yeah. Okay, let me try again.
The right medication can save a life, but a medication that works well for other people might not work for you.
For some reason, I don't have sound. Do you guys hear it?
Side effects. Pharmacogenomics is the study of how our genes affect the way our bodies respond to medications. Because of our genetic makeup, some people's bodies break down certain medications too slowly. The medication builds up in the body, causing severe side effects. Other people's bodies break down the same medication too quickly, eliminating it before it has a chance to work at effective levels. Yet others may be at risk for having significant, sometimes life-threatening side effects from a medication. Pharmacogenomic testing can identify variations in specific genes related to metabolizing or clearing certain medications from the body. Using this information, doctors can examine your genetic profile to predict whether a medication is likely to help you or hurt you before you even take it. The goal of pharmacogenomics is to provide the right drug for the right patient at the right dose. For example, if you have high cholesterol, your doctor might prescribe one of many statin medications to lower your risk of a heart attack. But these drugs can also have significant side effects. Finding that out can be expensive, time-consuming, and could delay receiving proper treatment. Pharmacogenomic testing is now available to show how your body is likely to respond to a certain statin. That may help your doctor prescribe the right dose of that medication, or even a different medication, to get the best results for you. Today, pharmacogenomic testing is available, which can help predict how an individual may process and metabolize hundreds of different medications, including those used to treat heart disease, high blood pressure, psychiatric disorders, pain, cancer, and many other conditions. Researchers are continuing to identify more genetic variations that affect the body's response to specific medications. Knowledge that is transforming the practice of healthcare by incorporating this information into your routine clinical practice. Talk to your healthcare provider to learn more about pharmacogenomic testing.
Interesting, Dr. Lizelle. I saw
You have to play that last video. You have to.
I couldn't copy it, so I think I can share with the colleagues in the groups, and then they can watch.
Okay.
Let me see. Yeah, no. Yeah, maybe as we go through some of the questions, I will try and see if I can figure it out. Then I can play
Last one is wonderful.
in between. Yeah. All right, colleagues. That is pharmacogenetics. Dr. Rizal, you can switch on your video if you are in a safe space to do that, so that we can just go through a couple of questions that will. Yeah, so maybe because there's a question, but I wanted to ask you how affordable are these? Should I call them tests or investigations?
Dr. Segha, to tell you the truth, it was a question that came up by me, but I don't know. I think a genetic counselor or a geneticist would be more up to date on that. I thought about that. I don't know if medical aid or health insurance companies, some in America, pay for that, but I don't know what the situation is in South Africa. Obviously, there should be such services, but how much they are and what they include. Obviously,
I see. I just did a quick search. It's about 2,000 to 5,000 rands per test. And it's in rands, so I assume it's available even here in South Africa. So, but the average price is around 3,500 rands. Is it worth it?
The person has got a debilitating disease condition and he or she is not responding. For example, on cancer therapy or mental psychiatric medication, obviously that would be indicated. Another thing is the HER, H-E-R gene.
Yes.
H-E-R,
yeah.
The HER gene that they test for breast cancer. I know that there were studies done a long time ago where they looked at ancestry, certain South African ancestry people, and what if those types of different surname people with different surnames had gene deviations, gene expressions of the hERG gene. So yeah, I would think in South Africa there would be tests like that. What exactly?
Yes. I do know that there are tests like that. I think in the previous years we had various symposiums on breast cancer, and we had a geneticist who always came up and talk about all this. So, and I saw as well in your closing slides. No, actually the videos that we were watching where they were showing the drugs and so on. I saw Maraviroc. Maraviroc is one such drug which we don't use in South Africa in the HIV space, but one of the tests that you must do is to determine if your patient, the virus they have is the one that prefers a specific receptor, the CCR5. So one would consider that in the private sector, should a patient need such, it will probably be done, though it's not something that we have in the public sector. Modise was asking, is the subject the same as pharmacokinetics? What would be the difference between pharmacogenomics and kinetics?
Genomics is pharmacogenomics is just it's built of two words, pharmacokinetics and genetics. So pharmacogenomics is the study of how different gene variations affect medications that we take. Pharmacokinetics is what what the body does to the drug. It includes absorption, distribution, metabolism, and then that differs also from biopharmaceutics and pharmacodynamics. So no, it's two different things.
At least when you say ADME, I have a reflection of what that is. At least I still remember something in that world. But I can actually see how the two sciences would work best for a patient. And actually, pharmacokinetics, it means we have studied the drugs and how it works. But we know that whatever that is, it's influenced by certain genes. So maybe if we can pick up the gene before we even give you the drug, that's how I understand what you have shared today. We can advise the patient that this drug will work, or if you take it, you may experience exaggerated side effects. So it's a very important concept, I think. Dion is asking, as a researcher, I often question the normal parameters of various enzymes tested during blood tests. If your physiological functions fall in or okay, it's got in and out, falls in or out of the normal bell curve, it can have serious effect on treatment. So I think Dion is asking about people who do not fall within the majority. The bell curve. It's your stats stuff, Lizelle.
Yes.
Yeah. So basically, I think it's trying to figure out whether these things apply to everyone, or there are people where the interpretation may not be the true. Should I say the interpretation we may fail to pick up the true effect of these drugs on certain patients.
For sure. That's why you want to take. We as healthcare professionals need to look at a patient in a holistic manner. If I take warfarin and you take warfarin, our responses might be completely different. I know you had a webinar a while ago. I think it was of liver dysfunctions.
Yeah, drug-induced liver injury. Yeah, I remember.
Yeah. Where the question was asked about INR. How does that differ when a person has besides that, what I want to say is we are all made up of different genes. Our responses to certain medications will differ. The question is why? That's why you have to look at age, gender, drugs, the medications that people are taking, occupational drugs, lifestyle, alcohol intake. I mean, all of that needs to be taken into consideration. And yes, there is a bell shape. And yes, 5% can lie on this side and 5% can lie on that
On
side.
the other side, yeah.
Yeah, so, yeah, basically what I want to say, there's not a tailor-made, one-size-fits-all cut-out pattern for all of us.
Yeah, because I don't know these tests, whether we should treat them like other tests, you know. So if the test says a certain patient has a certain hair type of gene or receptors on the cancer itself, how sensitive, you know, what are the possibilities of false positive, false negative, and that has to do with our understanding of the sensitivities, specificity, positive and negative predictive values. But I think if you take into account the clinical presentation of your patient, the type of cancer you are suspecting and how it is currently responding to certain treatments, and you look at the genetic profile, most likely you would agree or disagree with what you're looking at and then make the right call for your patient. Yeah, so thanks a lot, Dion, for your question. Do let us know if you have a follow-up or if we have misinterpreted it, because I got lost somewhere there. I don't know, you know, turnaround times. I don't know if Lizelle, you would know the turnaround times. If you do the test today, how long will it take to get the results? I'm trying to search for you as well in case.
No, I
Yeah.
don't know that because it would be well, it will depend on the laboratory whether or not that your specimen, your saliva or blood is sent overseas or not. I mean, is the equipment sufficiently for South Africa? And I for this presentation I didn't go into such
Yeah.
detail.
Yeah, I just saw days to few weeks. Sometimes it can even up to 10 days or even up to 3 weeks. It depends on the tests you are looking at and the lab and those kinds of things, you know. I've even heard when we have the geneticists here, there's certain profiles that are done outside the country because they are cheaper there than here, for example, you know, which was very interesting, sending a specimen outside the country just to improve the turnaround time. So I always thought that is quite interesting. Let's see, Dion is back. It would be interesting to explore the percentage of patients that falls outside the bell curve, so that we know the upper and lower, so your cutoff in terms of enzyme functions and other related parameters. Yeah, it can never be easy. As you process it, Lizelle, I know in the HIV space, we know that, for example, for a drug like efavirenz, we have always known that there are patients who are slow metabolizers of the drug, so they don't fall within the majority of patients are able to metabolize that drug very well. But we have never, like, in clinical practice, we have never had the need. It's only in the research world, Dion, maybe that's your area of interest, you know. And now we know, because these patients would present with these exaggerated neuropsychiatric side effects that persist beyond what we would expect. Some of them would even have serious toxicity, presenting with cerebellar signs, even something like Steven Johnson, because they would have high levels, toxic levels of the drug. We know when we were transitioning them to a better drug, DTG, most of them started to gain weight. So we now appreciated another effect of having high drug levels of efavirenz. So it means the toxic levels would keep these patients to be slim, you know. And then when we had a better drug, transitioning them to a better drug, patients started to gain weight, and people were saying, no, the new drug is causing patients to gain weight. But actually, it was the removal of the toxic drug that sort of allowed them to gain weight, you know. So it's very interesting because when we started the webinar, I couldn't think what you are talking about. But now, as I process your talk, Dr. Lizel, now I can see how these things are applied in different ways. And by the way, the same gene that makes patients to behave like this in terms of effervescence is the same gene that would affect the metabolism of INH, for example, in the TB space. And that means some of these patients may be prone to drug-induced liver injury. So yeah, it's not my world. It's just that sometimes when you read about side effects and why some side effects happen, then they tell you about all sorts of genes and stuff and proteins, and yeah, it's out of. I don't know if you have anything to add, because Dion is trying to figure out if there's a way that you can quantify, if you have 100 patients for the same gene, how many would fall outside. You said 5% this side. That's like a standard bell curve, right? We don't know whether this curve is central or it's shifting to the right or it's shifting to the left. There's all those things. But I think, Dion, it's a research question, isn't it? You need to collect data and see the shape of the curve and then determine who's outside the curve.
It's not a easy answer to anything in life.
Mm.
And I think one gateway that of benefiting our patients is pharmacogenomics. Because now we know what to look for. Or what to consider, for example, in treating of mental health conditions. And people suffering from HIV, for example. Now that you know the information that you've shared to me now has also been placed into like my bookcase of pharmacogenomics. So thank you so much for sharing that useful information.
No. That's awesome. That's awesome. Anonymous has a long question. Mine is not a question, but a noted differences in various responses by different patients. Oh yeah, so different patients on the same drugs and responding differently. Effervescence, some did better at 400. Yeah. And these would be your slow metabolizers. So these are patients, if we knew before we started ARV. So I think this is where pharmacogenomics comes in. So we could have had 10 patients. We could have had a genetic profile that tells us that Lesejo is a slow metabolizer. If you give them the 600 milligrams they would get exaggerated side effects. So maybe give him 400, or actually even don't give him. Maybe consider an alternate drug, And I see you're saying some tolerate Pharmapress and Alepril, others different drugs. Some have exaggerated effect on your statins and that's exactly. And you would see that Mayo Clinic is talking about individualized care, not care where we say one drug for all, but a choice of drug based on how we think the patient's body is going to react to the drug. So I think I'm getting there, Lizelle. So now I can go and read about it, because I think my eyes are getting open. But I think Anonymous is just basically sharing, I think, the experience of same patient, same disease, but reacting differently. And there's many reasons why that may be, but one of the reasons may be how their bodies are reacting to such drugs. Yeah. I don't know, Lizelle, if you have anything to add there.
No, I completely understand what you're saying. I think that's where integration between different health fields are so helpful and so wonderful.
Awesome, 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 awesome. Colleagues, I think this is it for tonight. We have to call it a night. But before we do that, we have an upcoming masterclass this coming weekend. Let me see if I can play the short video for you.
And then you ask yourself, does this result require triage or does this result require treatment? Nah. So you do a pap smear comes back, it says it's normal, it's obvious, we go back to screening. Now you do your pap smear and the pap smear comes, it says low grade SIL. So we're thinking here there's probably mild dysplasia. This can be caused by many things. Now it could be HPV, it could be some vaginitis, it could be the use of tampons and many of the things that sometimes go in there, resulting in cells that are mildly dysplastic. So this is an inconclusive result and it requires triage so that we know what is it that it really means.
Yeah, so if you wanna learn more about this one, colleagues, you know what you need to do. And I can't wait to see you this coming Saturday. So yeah, it's gonna be an awesome one. Dr. Lizelle, thank you very much for this topic. I mean, this is a very empowering talk. For some of us, we knew nothing. I'm talking about myself, and now I know something, and I've even started to figure out where it can be applicable in my clinical practice. Would you like to share your closing remarks, Dr. Lizelle, as we call it a night?
Dr. Segelin, once again, thank you for this opportunity. Second of all, thank you for sharing your information and in an integrated, clinical-based manner with us. Number three, I think one should become more aware of pharmacogenomic testing and find out, where it can be done. You said that it's about 3,000 Rand per test. And I think it lends out a huge, huge, huge opportunity for us healthcare professionals to liaise with one another and ultimately benefiting the patient who is suffering from a condition or a disease that needs treatment. So thank you so much for asking me to do this. This is really an eye-opener for me, and I hope that all the participants enjoyed it. And that one video, let's say, you need to make that go viral.
Yeah, no, I'm gonna find it and share it in our various groups, and yeah, and maybe also with the micro lesson, we will put all the links there, and then colleagues can watch it. Yeah. All right, colleagues, I've just shared a link. My team has asked me to share a survey, especially if you are not a member of the platform. We just want to understand you a little bit better because, like I said, from the 1st of October, most likely these kinds of sessions would be accessible to members. But before we make that decision, tell us, your views. What do you think of our membership offering? Is there a way that we can make it easy for you to join us on this journey? Dr. Makito says it's 3 rands per day, but for some of us, 3 rands is a lot of money. We could use it for other things, so we don't want to take it for granted. And actually, please, the link is in the chat there. So please do click it if you're not a member of the platform and give us some idea, if there are specific things that you would love us to look at in supporting you better. On that note, may I wish everybody a restful night with your families. Have a great weekend as well. Those of you who are joining us this Saturday, it's going to be an awesome one. Dr. Magagula loves issues around oncology and gynae, and he's about to finish his fellowship program. He teaches many things in obstetrics, but I tell you, when it comes to this topic, We have a long history, me and him, training doctors in rural areas how to do colposcopies when colposcopy was not popular and the older doctors preferred cold knife and taking patients, to to theater unnecessarily. And I think even today they are still there. If you come with a small lesion, they want to take you to theater, you sleep. I don't know, because colposcopy is an outpatient service, and also it minimizes the waiting lists that we have. I mean, we used to refer young women with one small lesion, like the one low grade, whatever, and they will tell you about an appointment 9 months from now because they must book theater. And you know how our theaters are always overused, or sometimes things are broken and stuff. And 3 weeks ago, like I said, we were in Swaziland, and we were with specialists and registrars and medical officers there, training them on the same things. So what we want to do this virtual part, but there's going to be a follow-up skills session where you would be doing the actual colposcopy. So if you are a medical officer, and I know many provinces bought these machines, by the way, but there isn't people who are confident to do the colposcopies. It's an outpatient service, so we can't wait. If you can join us, otherwise you can join us with a follow-up one. But I'm looking forward to the boot camp now, an in-person, where we will book patients and you'll be doing colposcopies under supervision. For me, it will be bringing back all those memories in the early days when we used to do that. And some of the medical officers, it's very interesting. They are still doing it in their sub-district. Some have bought the machines in their private practices, and you find that the whole region is referring all women with abnormal lesions to you. You do your own assessment there. We train you, and you know the lesions that you need to do a colposcopy. It's a curative treatment. You can cure those lesions. It's not some, I don't know, some side thing. You can cure these lesions. And then obviously if it's too late, the cancer has spread, colposcopy, then it's not the best, but we are going to discuss some of those so that you have an idea. You can also counsel your patients. So that is what this masterclass is all about. On that note, night, colleagues, and have a restful one with your families. Bye.
Missed our latest webinar? No worries. We know life gets busy, but your professional development shouldn't have to wait. That's why we've created webinar micro lessons, short, focused recaps of our full sessions designed to help you catch up quickly and still earn your CPD points. These bite-sized lessons are available exclusively to active subscribe members. So even if you miss a live session, you never miss out on the knowledge or the CPD points. Not subscribed yet? Now's the perfect time to join. Get access to all future webinars, every micro lesson and more. Visit www.clinicalcareplatform.com to sign up.
because they are the ones that clip, the ones that have the end that clips. You don't want that. It's a lot more difficult. Yes, it locks. It's a lot more difficult because now the procedure depends on you separating these two, putting them back together and separating them again. You want that process to be as seamless as possible. So you need a 10cc syringe, that's sterile. The black needle is 22 gauge, and they need to be at least 30 millimeters. So these are 5 or 25. This is 32. This is 32 millimeters. So you need to ensure that you have the correct level.
But with muscle, like I said earlier, is difficult to biopsy. It's harder, so you can say we might not be seeing a lot of cells there. But this would be sufficient in this particular context. Then the reports will become as like a spindle cell lesion, formal core biopsy would be advised, because it's difficult on cytology to actually just tell in most cases what is the type of the spindle cell lesion, especially if you don't have access to ancillary testing.
Yeah, this one I'm seeing is like VCV malaria parasites.
It looks like malaria parasites.
Yeah.
Yeah, those are spindle cells of the muscle.
Is it? Yeah, the tip.
Yes. Okay.
And then you ask yourself, does this result require triage or does this result require treatment? No. So you do a pap smear comes back, it says it's normal, it's obvious, we go back to screening. Now you do your pap smear and the pap smear comes, it says low grade SIL. So we're thinking here there's probably mild dysplasia. This can be caused by many things. Now it could be HPV, it could be some vaginitis, it could be the use of tampons and many of the things that sometimes go in there, resulting in cells that are mildly dysplastic. So this is an inconclusive result and it requires triage so that we know what is it that it really means.